Dr. Ashish Naba, and you all can, I hope you interact well as much as possible, because there's nothing to be backward about. We are here all of us are here to learn, including myself. So it'll be very good if you can interact. What do you, sir?
So good afternoon. I think some of the faculty left, well, it's their due, but I hope none of you left after the lunch and most of you are back here. Uh, so postprandial, as we say, it's a little, people are a little slow, but we'll try to put in some questions that are spicy enough to wake you up. The idea is not to intimidate in any way, but having volunteer helps, because a lecture can go in a little bit docile way, and but the quiz should be in the spirit of the quiz. I mean, uh, your wrong answer will not only teach you, but also many around you. And I guess you will go home much more happier to have attended the quiz than feeling no. Okay, so let's go. So I thought that ECG is not always about, or arrhythmia is not always about ECGs. What is the diagnosis here? Complete heart block, severe tricuspid regurgitation, SVT, AVNRT, or hyperthyroidism. Anybody? All through that last talk of coronary artery disease, somebody told you, remember, every time put it in the context of clinical, put it in the context of clinical. So many of the cardiologists sometimes stand at the foot end of the bed, not even pull the stethoscope out, not even auscultate, but just ask for the ECG to make a diagnosis, right? And then move to the next bed. I think that should not be the way. What do you see here? Is it fast or slow? Fast. And then when do you get that kind of, they call it frog sign, like the frog, in rainy season. Those those waves are prominent. That can happen only when the atria contracts against the closed AV valve. So, but it's fast, so it can't be complete heart block, right? Okay, which tachycardia then? I think that has only one tachycardia. No, it has a hyperthyroidism can have sinus tachycardia. Why would sinus tachycardia cause this? There is no a blocked AV valve, right? Wow, we always ask the ladies to do the honors first.
I'm Dr.
Yeah, you want to say?
It's AVNRT.
Great. So AVNRT, if you heard in the SVT lecture by Dr. Dunuville, you would have heard that the atria and the ventricle contract simultaneously because the circuit is small around the AV node, and when they contract simultaneously, obviously they are going to contract against a closed AV valve, and that's when you see that frog sign. So if you're careful about it, you can pick up the diagnosis even if the ECG was made. Any idea which diagnosis was made by the jugular pulsations even before the ECG arrived on the scene? Any idea of history? Well, Colombo is such a historical city. I mean, I see only history around me. Mobitz type 2, Mobitz type 1 was diagnosed by Karl-Heinz Wenckebach before the ECG was diagnosed by noting the difference between the jugular pulse and the pulsation. Huh? So that astute kind of observership is probably not going to be there in the present generation, is because the investigations and the imaging has improved so much that we come to feel that we don't require it, but then you're going to make sometimes big mistakes, and therefore clinical has to be never out of the window. Okay, so that's the spirit of okay. all through this morning session, and I appreciate the way the program has been constructed, right? It is so good that it is not syllabic like a textbook which can bore you. It is just filling in the gaps in your knowledge and reinforcing where you need to hear a little bit more. But I didn't hear anything about the Wals. Do they not have rheumatic heart disease in Sri Lanka anymore? They have? So come on, let's start with the Wals then, what we missed in the morning sessions. Which valvar lesion is most likely with this ECG? Severe MS, moderate MS, severe AS, or mild MS with severe MR? I mean, this is a crowd which is entering post, and therefore this is about trying to know what is there in which valve lesion and what are you seeing on the ECG. Very common question after you present your clinical case or the findings that the examiner eventually, if he's happy with you, pulls out the ECG and or asks you what would you see on a ECG or something like that. If there is for 10 seconds nobody, then I'll start throwing hints. But if there is some,
CVMS?
oh yeah, oh, only the girl smarter. That's what it is in India also. Come. MS. Why not? Why severe MS? Because
LA, uh, LA dilatation and also the RBB.
of the RB. A left atrial enlargement, obviously, and when it is for a long time, a critical mitral stenosis leads to severe pulmonary hypertension with the effect on the RV, which is seen as a right bundle branch block, and if you see carefully, or R in V1, you also have a right axis. But again, to the lady who got it right, mitral regurgitation also causes left atrial enlargement, so why not MR? The last option. If you get this right, then you said it. Otherwise, you had some toss of a coin. Why not severe MR? That also causes left atrial enlargement. Does severe MR, does mitral stenosis cause LV enlargement?
Yes.
Mitral stenosis. God save the Queen.
No.
Mitral stenosis
No.
will not cause any LV enlargement. In fact, the LV is underfilled because of the mitral stenosis, whereas mitral regurgitation will cause LV enlargement, right? Because the regurgitant volume is coming back to the LV. The LV will be dilated and enlarged. So you will also see signs of LV enlargement on the ECG. Do you see that? Do you see LVH or LV enlargement on this ECG?
No.
No, there is all poor progression only from V1 to V6. So that's why you are right when you say mitral stenosis and not mitral regurgitation. Anyway, somebody will note it that you made a good attempt. Okay. Now second question, this acute coronary syndrome, and remember a very good lecture was taken on this just pre-lunch, so I guess the lunch has not blurred your mind. This acute coronary syndrome is non-STEMI. A emergent CAG was done by the same person who gave that lecture. All findings are possible which I have put up in the angiography except one. So the question is asked in a little bit different way. Same ECG I am showing you, and I don't know why, trying to be a friend, I have also highlighted where to look at. Superdominant RCA with ostial tight stenosis. Left main coronary artery ostial stenosis. Wrap around LAD ostial stenosis. Or this is almost a critical triple vessel disease. Only one coronary finding is not possible when you get this ECG of non-STEMI, non-ST elevation myocardial infarction. Anybody? Now you want some boy. Girls are barred from this question. They are too good.
Superdominant RCA with ostial
Sorry?
Superdominant RCA with ostial tightness.
Where is that? I don't see you. What did you say?
First one, superdominant RCA with ostial tight stenosis.
She whispered into your ear. No, you are right. So here is some example. Many times when you have left main coronary artery stenosis, these people will usually have a sudden cardiac arrest or a sudden cardiac death. When you resuscitate by giving a CPR, the first ECG that is recorded after return of spontaneous circulation is very important. For example, you may have a ECG like on this, ST depression everywhere, ST elevation in AVR, suggestive of left main coronary artery. You do a angiography, show that and stent the left main. The question is that what made you think of these left main coronary artery? When left main coronary artery is involved, the ischemia vector, the injury vector of the ischemia, left main coronary artery supplies the base of the LV. So the injury vector is directed towards the AVR, as you can see on this slide, that arrow there. That dark shaded area is the area that is getting ischemic, and the injury vector is directed to the right shoulder, and therefore the AVR shows ST elevation, as you can see here or here. So when you see ST elevation AVR, somebody said that it is neglected lead. Well, you should not neglect it. ST depression in most leads, ST elevation in AVR can mean left main coronary stenosis, it can mean ostial LAD stenosis, it can mean a critical triple vessel disease. Only RCA stenosis will not give rise to that, yeah? So that is the understanding that you should have. Here is another question. Have you heard of TAVR and TAVI? That is the latest rage in invasive cardiology or structural heart disease. Almost everybody in India wants to do TAVI except the electrophysiologists, luckily. They are all mad after TAVR, TAVI. Here is a question that is besides the point. Question is, this patient has undergone a TAVI. Most likely pacemaker implantation will be required. The interventional cardiologist knew it beforehand that this patient will need a pacemaker. If you don't counsel and tell the patient afterwards for the first time, you will give him a rude shock. This patient should be counseled that they will need a permanent pacemaker. What was the strongest predictor that told him that this patient after TAVI will need a pacemaker? That this patient has sinus tachycardia, that this patient has indeterminate axis, that this patient has RBBB, or that this patient has a fractionated QRS. These all questions are not to test your knowledge of TAVI, they are to test your knowledge of anatomy and ECG. So even if you are yet to enter post-graduation, don't worry, this is not supposed to be over your abilities. This can add to your understanding of anatomy and ECG. This patient will definitely need a pacemaker. Anybody? For that you should understand the relation of the aortic annulus to the conduction system. I will show it to you in picture. You will not go home without having learnt. My promise. Anybody who can answer? The right bundle is already blocked. What must block to create the need of a pacemaker? A complete heart block should happen. For a complete heart block should happen, what should happen now to this patient with the right bundle? See that right bundle? He has a right bundle branch block. This is pre-TAVI. What should block to create a complete heart block? The left bundle should block, right? Then he will have a complete heart block. Why does the left bundle block in a TAVI? This is the bioprosthetic aortic valve which is put at the aortic annulus. You see on the right, the left is where the valve is put at the annulus. The right you see how the left bundle or the bundle of his penetrates the area between the non-coronary and right coronary cusp. Everything is labeled there. And then it becomes the left bundle trunk, and then it bifurcates further into left posterior and anterofascical. Your valve is placed a little below the RCC and NCC. If it is expanded there, then it is going to compress on the conduction system. Some of them are even self-expandable valves. Over the time they will expand and they will press on the left bundle. You will get a complete heart block. If he already has a right bundle branch block, your pressing the left bundle will give a complete heart block. See, this is how the valve is put. For some of you who may be enthusiastic to take cardiology in distant future, I must say, isn't it? You have how many years of medicine to do? 3 years? So in distant future, if you are going to take up cardiology, then this kind of pictures will interest you. See, that valve is put there and then it can cause a complete heart block. Anyway, let's go on. Again, ECG question, nothing to do with all the nice things that I have put on the slide. What is the location of the left ventricular scar? What usually tells you about the scar? What in the QRS tells you that there is a scar there? Post infarct, how do you know there is an old infarct in that region? Which wave tells you that there is a scar? Q wave, right? When you get an anterior wall infarct, you get Q in V1 to V4. When you get a inferior wall infarct, you get Q in 2-3 A wave. So what has been imprinted on your mind? When I see a Q wave, I will call that there is a scar underneath it. I want to teach you something more. What is the location of LV scar? It's confirmed on MRI. Have you heard of cardiac MRI? Or you have heard only for brain MRI? Cardiac MRI is also done to delineate the scar. What is the location of the LV scar? I bet you can't tell. Tell me. Scratch your head. There is no scar, I say. There is an anterior LV wall scar. There is a posterolateral scar. There is a apical aneurysm. This is the ECG. Where is the scar? This ECG tells you that there is a scar in the heart. Where is the scar? You read what, Shamrod these days or what? Which book you read for ECG? Where is the scar? Can you see any important Q waves? You know what is the significant Q wave, right? More than 1/4 of RR and things like that, or broader Q wave, more than one small square, then it is scar. Do you have it here? No. Inferior leads are having RS, not Q. Or V1, V2, V3 are having very small Q, which you can call insignificant Q. So then where is the scar? Silence is golden. All Buddhas here are golden. Loss of R wave. Okay, let me start throwing hints. Loss of R wave is scar. Where is the loss of R wave here? There is a prize waiting at the end. I don't see any takers for that. Where do you see the loss of R wave? You remember somebody taught you about the progression of R wave in the precordial leads? You were sleepy by the time of 4th lecture. Yeah, they showed V5 has to have the tallest R and then V6 can be less. But here V5, V6 has absolutely no R. That's not acceptable. That's not normal. And where do you see extra R? V1, V2 has big R. Remember posterior wall infarct, how they taught you? Posterior wall infarct, acute ST depression, maximum in V2. Unlike the ST elevation, it is mirror image. No, anterior leads are mirror image of the posterior wall. Similarly, a Q wave in the posterior wall scar will be looking like a R wave in V1, V2. Now can you add up? Where is the scar? And pick the right answer. Now. Nobody is going to cross that examination, I think, the national examination. Posterolateral, no? Posterior I say because there is R in V1, V2, and lateral I say because there is a loss of R in V5, V6. She wanted to answer? Oh, I came in first. Yeah, you can stand up and explain. If you understood what I said, you can repeat, even that's worth the money. That's worth the ticket that USV gave me. Tell me. You understood? What you understood? Why is there a scar in the posterior wall?
Usually there is a high R waves in the V6, V5, V6, but
Excellent.
here it's very less.
Loss of R wave is also scar, yes.
Yeah, and also in the V1, V2, V3 in the posterior wall infarction, there will be a ST depressions. But
Here it is not about ST, here is about the QRS. Normally, if there is a scar, you see Q wave.
Q waves, so here
But
small Q
posterior
waves.
wall, the V1, V2 are mirror image to the posterior wall. So the Q waves in say V8, V9 will look like R in V1, V2. Thus the prominent R in V1, V2 is posterior wall scar. One of the, in dilated cardiomyopathy patient, there are different ECGs. One, if there's a lot of scar in a patient with dilated cardiomyopathy, you'll have low voltage QRS in all the leads. So loss of voltage is also equivalent to scar is what I wanted to convey. Yeah? Okay, we are moving fast. Following is the course in the ICU. What is the best plan for this 65-year-old lady? Look at the first ECG, there is a complete heart block. You can see that? The ECG on the left is complete heart block. She had Stoke Adams, a TPI was put, and as she landed in the lap of an invasive cardiologist, what did he do first? He did a coronary angiography. Every invasive cardiologist starts the patient with an coronary angiography. So he sees complete heart block, he does an invasive angiography, it is normal. Yeah, he congratulates the patient, your angiography is good. And then on day 4 what happened? There was 1-to-1 conduction. So he removes the pacing wire and prepares the patient for discharge. How did this patient come in? Complete heart block, Stoke Adams, requiring temporary pacing. On 4th day he says you have resumed conduction. Now you can go home. What should be the way to go ahead? Give him a 7-day loop recorder or a Holter, and if he shows blocks on the ECG, then consider doing a pacemaker. The patient was on beta blockers. So stop the beta blockers, and if patient has pre-syncope or syncope, then consider if he needs a pacemaker. Before discharge, give him a dual chamber pacemaker. Or as the invasive cardiologist did, reassure the patient, angiography is normal, you are going to live 100 years. You don't need anything. Yeah? So what is the good answer? Does he need a pacemaker or not is my question.
Dual chamber pacemaker before discharge.
Sorry?
Dual chamber pacemaker.
Yeah. You are right, but if you are right without a reasoning, I don't count it in. What is the reasoning? He's recovered the conduction 1-to-1. If you tell the invasive cardiologist that he needs a pacemaker, he will say your hands are itching just like mine are for angiography. He will dispel your theory of needing a pacemaker. You have to argue why so. I am showing you the recovery ECG. I am not showing you the complete heart block. That was obviously there. It was pacemaker there also. But he recovers. That is the point of contention between the two cardiologists. One says AV conduction is recovered. Why pacemaker? The other says no. Despite AV conduction recovered, I still will give him a pacemaker. Why? Is there any bundle branch block in the recovered ECG? That's where the money is. You said pacemaker because I was a EP taking a. Tell me.
Does a right bundle branch block with the left axis deviation?
Right bundle branch block, sure. But only right bundle branch block doesn't make him a pacemaker candidate, na?
Axis deviation of the left axis deviation?
Well, you can call it slightly rightward if you don't mind. One is little equidiaphasic. And you have small q in 2-3 AVF. So that becomes what? Right bundle branch block with left anterior fascicle or left posterior fascicle. This is pure undergraduate. Huh? This is not some hi-fi. If the axis is moving rightward and you have small q's in 2-3 AVF, is it left posterior or left anterior? I know why you are taking so much time, because left anterior hemiblock you see frequently and you can diagnose. Left posterior hemiblock you don't see frequently. So you have not seen them in your career till now, I guess. But then see it with your eyes wide open this time. Yeah, it is a left posterior hemiblock. You have small Qs in 2-3 AF and the axis shifts to the right when you have left posterior hemiblock. So this is already bifascicular block despite recovery of 1:1 conduction. So in a patient who has already manifested complete heart block, this ECG says that he has degenerative conduction system disease and nothing that was reversible. Don't talk of electrolytes, ischemia and things like that. It is degenerative conduction system disease. So it does need a pacemaker. What happens is that the left posterior hemiblock are not seen so much. Why? Because left posterior system is, so first run to diagnose a left posterior hemiblock. Yes, it is less common, the axis is shifting to the right. When it is with a right bundle branch block, it means it's a bifascicular block. But the reason it is not common is because left anterior fascicle is on the anterior surface of the LV, more prone to stretch and more prone to easily block, whereas left posterior fascicle is on the septum, it is a little broad. It has a dual blood supply from the septal vessels from the left anterior descending as well as from the septal perforators from the posterior descending. So therefore left posterior fascicle is less prone to block. You don't see it that often. Left anterior fascicle block you see many times, right? So therefore left posterior fascicle block along with RBV is still a bifascicular block and needs a pacemaker. Here is another question. This patient has symptomatic atypical atrial flutter. The attending cardiologist decided that it is good to give him sinus rhythm. Yeah, atrial arrhythmia, as you heard in one of the supraventricular tachycardia presentations, that one way to restore sinus rhythm is not to give adenosine or beta blockers or what is that, verapamil, but you can either give a rhythm control medication like cordaron or amiodaron, or you can do DC cardioversion. Now in this case, patient has atrial flutter, a DC cardioversion was considered. The question is, which amongst the following adverse outcome after DC cardioversion? Yeah, many people, many cardiologists also or physicians are worried about doing elective DC cardioversion, and the patients are still more worried to undergo this procedure. But it is a well documented, well done procedure because it can restore sinus rhythm almost 85 to 90% of times, unlike your drugs. So therefore DC cardioversion is a way to restore sinus rhythm, but there can be certain adverse outcomes. Which one of them is possible? Complete heart block is possible after DC cardioversion, stroke is possible, immediate recurrence is one more thing that makes the patient unhappy, or all the above. So what do you think is the counseling that is required when you are advising elective DC cardioversion for this patient? Do you know that there is a stroke risk with DC cardioversion in a patient with atrial fibrillation because of small clots that can be there in the left atrial appendage? So you have to either anticoagulate them for 1 month before DC cardioversion, or you have to do a transesophageal echo and show that there is no clot, yeah, and then you can cardiovert when you are doing electively, not for emergency. So stroke is definitely a possibility. Can the atrial fibrillation recur after you cardiovert, or atrial flutter recur after you cardiovert? It happens the same day evening, the patient says, I was not given the right advice. No, if the LA volume is large, most importantly, if the LA volume is large, or if there is already a valve regurgitation, or if there is a long-standing atrial flutter or fibrillation, these patients are likely to get back into AF. So that can be considered as an adverse outcome if you like. But why complete heart block? Somebody said that in the SVT talk, right, you could, instead of ablating AVNRT, you could do DC version. So is it that your external DC cardioversion can create a complete heart block? Have you heard of that? Can your external DC cardioversion create complete heart block? Is it one, if you choose all of the above, then you have to consider that DC cardioversion is a possibility, creating complete heart block is a possibility. Can this patient get complete heart block because of DC cardioversion? Any takers? How can this patient get complete heart block because of DC cardioversion? Is it possible? Is it known? That means you didn't read the ECG carefully. What is the ECG showing? Flutter would usually have, most atrial tachyarrhythmias would have heart rates that are faster, say above 100 or 100 to 150 or whatever, in that range. What is the heart rate in this patient? 40 or so. What does that mean? When you have a fixed slow heart rate in a patient with atrial arrhythmia, what does that mean? There is an underlying AV conduction problem, so much so that this patient has an underlying complete heart block. If you didn't counsel your patient that you are likely to need a pacemaker, a DC cardioversion is only going to restore sinus rhythm so that the pacemaker works better. If you didn't have that understanding, the guy will be upset with you that your DC cardioversion caused a complete heart block. DC cardioversion never caused complete heart block. Yeah? So your reading ECG is a part of good counseling eventually that you will have to do before you do elective procedures. The elective procedures can be more, yeah, patients can be complaining more about a DC, about an elective procedure than about an emergency procedure. Okay. Here is something. These are two different ECGs. What they show in common is it is relatively narrow, regular tachycardia. With, if you look at V1 in both of them, right bundle branch block pattern. And if you look at the axis, the first one has negative in one AVF, so that is northwest. Here it is one positive AVF negative, left axis. So the only difference in this narrow QRS right bundle branch block regular tachycardia is one has a left axis, one has northwest axis. I tell you in addition that there is no structural heart disease. So this is typically, make a photographic memory. You have camera in your eyes, make a photographic memory. This is idiopathic left ventricular tachycardia or fascicular VT. Yeah? Got that? Now remember this. Look at these ECGs carefully. I said take a photograph with your eyes, because the next question should not floor you. You saw them carefully? Now, and one more thing is disparate axis. Whenever you have a tachycardia, despite being a narrow QRS tachycardia, if a right bundle branch tachycardia has a left axis or a left bundle branch tachycardia has a right axis, it is going to be VT, because the bundle branch block and the axis usually go together. Okay. This is the question. Narrow QRS regular tachycardia. What drug would you prefer for acute termination? This is 1 in million ECG. What did I teach you? Right bundle branch block, narrow QRS, regular tachycardia, in this case left axis. What is the diagnosis for you? What tachycardia I said it was? One I said it was ventricular tachycardia. The second I said it was fascicular VT. These VTs come very close to the conduction system. The left posterior fascicle usually. Therefore they are narrow QRS. I didn't tell you that last time. So, right bundle branch block, narrow QRS, regular tachycardia, left axis. Is this fascicular VT is the question for you. Accordingly you will shoot the drug. You are standing in the casualty, or how do you call it, EMS or accident and emergency. What do you call in Sri Lanka? So you are standing there all alone. This is the ECG. Probably you didn't take a history. You will give IV verapamil. You will give IV adenosine. You will give the safest drug on the earth, IV amiodarone. If you don't understand anything, give amiodarone. Huh? Yeah, they taught you like that? Or give oral flecainide. You went to one of those ECG sessions and heard about that pill in pocket approach. Give a big dose of the drug and the oral drug will work as well as IV drug. Huh? So, this is the ECG. What drug will you give? You have all four available through the health system in your casualty. What drug do you want to give? Fascicular VT, I tell you, responds very well to verapamil, IV. If it was so simple, then I wouldn't put the question, right? I'll make you walk on a thin wafer of ice and then you will drop. Which drug you want to give? Adenosine, because I like that drug, it works very fast. Verapamil, because this is fascicular VT. Amiodarone, because if I don't understand anything, amiodarone is a wonder drug for me. Or flecainide, because I have heard it in elegant
arrhythmia meetings that this is the way they do it nowadays. What is your logic? Your logic has to rest on the ECG. Does it satisfy the criteria for a fascicular VT? Yeah? Narrow QRS, regular, right bundle branch block, left axis. What I didn't tell you was about the structural heart. But you can you judge that from the ECG? What you see here is that there is a QR pattern in V1, V2, V3. You see that? Now look at the ECGs at the back. These are fascicular VTs with right bundle branch block, left or northwest axis. But do you see any QR pattern here? Remember we started the discussion of scar, talking of cues. We don't like the cues because they indicate scar in the ventricle. So you are very likely to be fooled in this case by right bundle branch block, left axis, narrow QRS, regular. But this is not fascicular VT. This is VT coming from the interventricular septum in the setting of an old anterior wall infarct. How do I know it's old anterior wall infarct? Because there is a QR pattern in V1 to V6. Whenever you get a broad QRS tachycardia, and I think that talk is coming next, when you have to find the etiology of the broad QRS tachycardia, if you get a QR pattern in any of the leads, it tells you that there is a scar underneath those leads. In this case, V1 to V4, V3, or even V4 pattern. So QR pattern, not QS pattern anywhere, but the QR pattern tells you that there is a underlying scar. So this is a post-infarct VT coming from the septum. And why it is narrow despite being a VT is because just like fascicular VT coming close to the conduction system is narrow, this VT coming from the interventricular septum. So when you have a VT coming from the interventricular septum, it will activate both the ventricles simultaneously. And that's for the QRS will not be that broad as you see in other VTs. So therefore, you are not to be fooled by calling it, if you give verapamil to this patient, it will crash. Adenosine will not terminate. Only cordron will work, not because it is cordron, because cordron works in VT. Yeah? And of course, will not give flecainide because you know that in structural heart disease, you don't give class 1C drugs. Okay, I think we are having more of this in the next talk probably also, or we learnt a bit of this. What makes the QRS wide during the tachycardia? One is the tachycardia could be coming from ventricle. So by and large, 85% of your ventricular tachycardias are with a wide QRS because they come from the myocardium. They activate the ventricle, the first, if it's coming from the LV, it activates the LV first and then activates the RV. Plus it is myocardial cell-to-cell activation. Therefore the QRS is broad. So any tachycardia coming from the ventricle, or in other words, ventricular tachycardias are usually wide QRS tachycardias. The other reason they can be blocked is shown in the B. B shows that a supraventricular rhythm comes down by the axillary pathway on the left side. That is also what you heard this morning. Pre-excited tachycardias or antidromic tachycardias coming down the axillary pathway up the AV node, or atrial fibrillation coming down the axillary pathway. All of them activate the ventricle by cell-to-cell activation, not through the conduction system. So they are broad. And the third is they are very well coming down the conduction system, but one of the limb of the conduction system is blocked. Then you will get either a right bundle branch block pattern or a left bundle branch block pattern in a supraventricular tachycardia, and therefore naturally it is a wider QRS. So that is the thinking that you must have when you are looking at wide QRS tachycardia, and not steal the show from the next talk where you will hear more about that. But let's look at the ECG. ECG 1, wide QRS regular tachycardia. Okay? And ECG 2, when sinus rhythm was restored, it helps you. Looking at two ECGs helps you somewhat, but you have to look carefully. Yeah? Look carefully. Let me put in that, look carefully at the polarity of each lead and compare it lead to lead. So wide QRS tachycardia, sinus rhythm restored, this is the ECG. Yeah? And the question is obviously what tachycardia it is. Let me not confuse you. Let's not put it, let's discuss it like this only. What does the ECG 2 show you?
You had this discussed in the second talk. The second ECG shows an inferior wall infarct or it shows something better, different? Q in 2-3 AVF, is it an inferior wall infarct? No, the onset of the QRS is slurred. What is that slurred onset called? Delta wave like onset, right? So this is pre-excitation. Yeah, it is a pre-excitation inferiorly, and V1 has kind of also Q and lead V2 has R, so it is septal. So this is a, if I were to even tell you to forget all this, knowing that you are yet to do your MD medicine, this is a pre-excitation pattern. That much you can understand if you remember what was told to you in the SVT lecture. Yeah, short PR, slurred onset, wide QRS, that is pre-excitation. Now if you compare this pattern lead by lead with the ECG above, does it match or not? You compare lead by lead. Lead 1 to lead 1 there, lead 2 to lead 2 there, lead 3 to lead 3 there. Does it match polarity wise? Yes or no? How can it match? Pre-excitation means the supraventricular rhythm is coming down by the accessory pathway. That's why it makes this ECG. The only difference is the polarity is the same, but the QRS is still wider. So that means the antegrade activation in that ECG is also happening by the accessory pathway. Now how is tachycardia forming? Retrograde lead is going by the conduction system. So most accessory pathways have orthodromic tachycardia, meaning down by the AV node, up by the accessory pathway. Therefore they are narrow QRS. But 10-15% of the times you will have people with pre-excitation having an antidromic tachycardia. Anti means against the AV node ka direction. So it is down by the axillary pathway, up by the AV node, reverse of what I said earlier. Down by the axillary pathway means the QRS is broad, up by the AV node means the circuit is complete. So you have a wide QRS tachycardia which looks exactly like your pre-excitation pattern. So that is an antidromic AVRT, AV reentrant tachycardia, which is moving in an antidromic direction, down by the axillary pathway, up by the AV node. Yeah? Somewhat clear? No big yes. I have a limited time. I must move on. Okay. Let's, this is the same, I will make it less complicated. Okay. Okay, let's not go too much into deep. What is happening here? Again, this was discussed. We'll not discuss the location probably, but what is happening here? What is the rhythm? Is it wide QRS or narrow QRS? That's how you have to classify your tachycardias, right? Wide QRS, narrow QRS. Somebody should stand up. Or is it sometimes wide QRS and sometimes narrow QRS? Which one is good for you? Wide QRS, narrow QRS, sometimes wide, sometimes narrow. Which one is good answer? Obviously the third one. Sometimes wide, sometimes narrow. When you look at the tachycardias, you have to look at the rhythm strip at the bottom. Forget that. Look at the rhythm strip. It starts with a wide, and then gets narrow, and then again wide, and then narrow, and again, yeah? So wide and narrow, wide and narrow. Is it regular or irregular? Is it regular or irregular? Obviously irregular, no? It is tachycardia, all right. It is sometimes narrow, sometimes wide. Sometimes it is regular, in most times it is irregular. So what is that? Fast, broad, irregular, FBI. What is that? It is pre-excited atrial fibrillation. Means what? Means what? You have atrial fibrillation in the atrium. The atrial fibrillation in the atrium will come down by the AV nodal conduction system, but then it should result in a narrow QRS. When it would result in a broad QRS? When either while coming down the AV conduction system, one of the bundle branches has a rate related block, then it would come with aberrancy, or there is an accessory pathway. Then it will come down by the accessory pathway sometimes and sometimes by the AV node. So when you have this kind of a fast, broad, irregular tachycardia, when it is broad, it is coming down by the accessory pathway, the atrial fibrillation impulses. Yeah, atrial fibrillation is happening at the rate of 300 to 600 in the atrium. But all this time, AV node was acting like a gatekeeper. It did not allow those 300 to come down, otherwise you'll get a VF. So the AV node was working as a gatekeeper, only allowing 130, 140, 150 to come down. But the axillary pathway is not so good. The axillary pathway will allow everything to come down. It does not have the decremental properties of a AV node. And therefore, when it allows fast to come down by the axillary pathway, you have broad QRS. At the other times, when it's little slower, the impulses are coming down the AV node. So when you get this fast, broad, irregular, again take a photograph of this in your eyes, through your eyes, and imprint it on your brain. Fast, broad, irregular tachycardia is pre-excited atrial fibrillation. Yeah, it tells you that there is an underlying accessory pathway. This is, as was told in the talk, again a kind of a medical emergency. You have to restore sinus rhythm fast, maybe by DC cardioversion most of the times, and plan for ablation this week. Yeah, because the next time you may not be lucky because there is a small risk of sudden cardiac death with this. Okay, I think I am to the last one. Okay. Right. So this 26-year-old guy, young guy, has palpitations, syncope. What is the best treatment option? Yeah, young guy has palpitations and even a syncope. What is the best treatment option? To give the treatment, once again you must read the ECG carefully. So what is the kind of tachycardia? Narrow QRS, wide QRS? Wide QRS tachycardia, right? What is it, regular or irregular? It is regular, but it is stopping intermittently, and therefore you have a sinus beat. These sinus beats in between are not capture beats. It is tachycardia terminates. You get a sinus beat, tachycardia reinitiates. That is what is happening. So it is wide QRS, regular, non-sustained, repetitive kind of a tachycardia. Then what is the morphology of the tachycardia? Look in the lead V1. Is it left bundle branch type or a right bundle branch type? What is the morphology in V1 looking like? Like a left bundle branch pattern or a right bundle branch pattern? If you have a QS kind of pattern in V1, it is a left bundle branch block pattern. So you have a left bundle branch kind of a wide QRS tachycardia. Now a left bundle branch tachycardia usually will come from the right ventricle, whereas a right bundle branch block type of a, I'm not calling bundle branch block, I'm saying characterizing it. I'm only describing it. One which has a QS in V1 is left bundle branch block type tachycardia. Whereas if you have R in V1, it is right bundle branch block type tachycardia. So a right bundle branch block type tachycardia comes from the left ventricle. Obviously, no, if you have a tachycardia which starts in the left ventricle, it would activate the left ventricle first and the right ventricle later. So a right bundle branch block pattern. If you have a tachycardia which starts in the right ventricle, it will activate the right ventricle first and then the left ventricle. Therefore a left bundle branch block pattern, because that contralateral ventricle is activated late. So if you have this left bundle branch block kind of a tachycardia, then which disease involves the left ventricle commonly? So what would be the answer? ICD, sotalol, ablation, or amiodarone plus pacemaker. Let me not take you into this. This is a left bundle branch block tachycardia coming from the right ventricle. So what is the right ventricular disease that you know? Do you know of a right ventricular myocardial disease? There are certain cardiomyopathies that are called as arrhythmogenic cardiomyopathies. The most commonly described or the initially described was right ventricular cardiomyopathy. We call it ARVC, arrhythmogenic right ventricular cardiomyopathy. Why this name? Because these cardiomyopathies may not start with a ventricular dysfunction first, they may start with arrhythmias first. Normally one understands that when ventricular dysfunction happens, the arrhythmias happen. But in arrhythmogenic cardiomyopathies, many times the arrhythmias present first and then you will see the dysfunction of that ventricle. So one of the important investigation there is a MRI. I'm sure you can identify from your anatomy knowledge, short axis view, left ventricle, that side right ventricle, here it's obvious, left ventricle here, that is the right ventricle. So if you look at the border of the right ventricle, it is crenated like this. Crenated. In arrhythmogenic right ventricular dysplasia, there is fat deposition, adipose replacement of the myocardial tissue. That's the reason it becomes weak and crenated with maybe small aneurysms like that. So this is ARVC. Nowadays we know that the arrhythmogenic cardiomyopathy can also involve the left ventricle. We call it ALVC. Yeah, and then can be biventricular also. But this is typically an ARVC, arrhythmogenic right ventricular cardiomyopathy, when you can have tachycardias coming from the right ventricle, which will look with the left bundle branch block pattern. Whenever you have ventricular tachycardias in structural heart disease, it means ICD first. Yeah, that's how the question was. Maybe one last to go. What is the best treatment option for this non-sustained VT? You can see downstairs in the rhythm strip, sinus beats, then wide QRS, sinus beats, wide QRS. So this is ventricular tachycardia happening. Yeah. What is the morphology of this tachycardia? Most important to see is, if there are tall R waves in 2, 3 and AVF, I tell you the echo is normal. So when you get VT in a structurally normal heart, they are called as idiopathic ventricular tachycardias. When they have tall R's in 2, 3 and AVF, like you see in the PVC beats or the non-sustained VT beats, yeah, tall R in 2, 3 AVF, they are activating the heart from superior to inferior position. If you have tall, this is understanding your ventricular activation, nothing more. This is not hi-fi. If you have tall QRS in 2, 3 AVF, the activation of the ventricle is from cranial to caudal, from top to bottom. And which anatomic part of the ventricle is situated cranially? The outflow tracts. What is situated basally are the inflow tracts. If you know the anatomy, the mitral and the tricuspid annulus would be inferior, the outflow tracts would be superior. So if anything comes from the outflow tracts, they would activate the ventricle from that starting point craniocaudally, and therefore your 2-3 AVF will be T coming from the outflow tract. This we understand as idiopathic outflow tract VT. Again, this might be a little ahead for you, but they are very suitable for ablation. I think these are couple of points that I wanted to make, and maybe they will add something to your present understanding of ECGs in general and of the diseases in a little particular way. Thank you very much.
Okay.
Thank you very much for that very interesting and eye-opening ECG quiz. And to present Dr. Ashish Nabha with the token of appreciation, let me call upon President of Sri Lanka College of Cardiology, Dr. Sankatunubila. Our next speaker is